Chris Wilson, welcome to the podcast, man. I appreciate you coming on.
I appreciate you having me.
Yeah, I think you may have the literal shortest commute. You didn't walk here, did you, from the Star?
No, I had to take 2 exits, but it was a really short commute, and I'm glad it was so convenient, so thank you.
Yeah, no problem, man. I mean, I would presume you probably like officing out of the Star, right?
It has a lot of benefits to being in the Star, and really the reason we're in the Star is to get access to people that want to come visit with us because, as you know, access is the biggest thing. We have a challenge in our industry is getting to meet with decision makers. So
Sure.
It's a great recruiting tool to have people come spend not only time for a meeting, but also social time and walking over to interact with them for happy hour or lunch or what have you.
Yeah, and so for the people that don't know, the people that aren't in Dallas that are listening to, the Star we're referring to is the Dallas Cowboys headquarters, obviously appropriately named the Star, has what is it? It's a practice field, but it also has a dome stadium, right? They're doing high school games and some collegiate games there, aren't they?
Yeah, so the Star actually is a planned development by the Jones family, and it's the corporate headquarters of the Dallas Cowboys. And so everything Dallas Cowboys is centered around the Star. Interestingly enough, when the Star was being developed, we were looking for office space. And the Star has, as you said, practice facilities. It's a joint venture between the city of Frisco and the Dallas Cowboys. So all the Frisco high school teams share that stadium, the indoor stadium, as their home stadium. And the Cowboys practice inside the home stadium, but they also have a field, 2 fields actually, that overlook, the building overlooks. So we're in the building that overlooks the practice facilities where they practice throughout the year.
Okay.
And a lot of people want to come in and just see that. But what they also don't understand is we actually look into the Cowboys boardroom.
Do you really?
We're in the atrium, and our CEO had the first choice of the office location in the Star. So his first question was, where are the Dallas Cowboys? And they said second floor through on the left side. And he goes, well, I want to be on the right side, second floor. So we actually look into their offices.
That's pretty cool. And I wonder, they've got to have some restrictions, right, when they're practicing? Or, I mean, is there rules about, you obviously can't take video while they're practicing, correct?
That's it. The only rules are no social media posting of any practices via video or photos. But you can look out on the field, and people do look out on the field and watch and observe. But really, if they're going to do anything that's strategic, they go indoors to the Ford Center, which is the indoor facility.
Sure. Yeah, I'd imagine so. But it's also, don't disrespect the location that you're at, right? Like, it's a privilege to be in a building like
Absolutely.
that. And so you certainly wouldn't want to jeopardize your standing. And so, maybe you host somebody that's a Pittsburgh Steelers fan or something like that. And
Often.
decides, was that?
Often.
Yeah. So I wonder, is it a double-edged sword? You get some people in that just hate the Cowboys probably as well, right?
You do, but what's funny is the experience is so unique that they don't really care that it's the Cowboys. The Cowboys have a brand, kind of like the Yankees. It's bigger than the sport. So even if they're not a fan, they appreciate the history and the development, and so they still have a wonderful experience. They still want photos. They still want to see it and experience it because Jerry Jones has a personality that transcends football.
Oh, yeah. Oh, and everything they do is first class. My wife and I work out at the Cowboy Fit gym, and so everything they do is top notch. So irrespective of what your opinion is of the Cowboys or even football in general, you understand what you're getting with that brand, right?
Absolutely. First class.
I think there's a funny story to share. You and I had never actually met in person, right? And then we're scheduling this and trading emails and things like that. The day of that we actually get it locked in, I'm randomly at the Star at Tri-Tip grabbing some lunch, and, lo and behold, you walk in the door. And it was kind of funny. It was a serendipitous moment because I've been up there for years.
Absolutely.
We've never run into each other. And the day that we lock in the podcast, we run into each other.
That was very unique, and it was interesting and almost one of those things that makes you think, how small of a world it is, and especially in healthcare.
Yeah.
We run into people all the time at the Star, but to have that interaction and see you that very day was very interesting.
Well, and I was on one of those Clubhouse, that app where people have. So I was on, a colleague of mine. He hosts, I think, a weekly Brand or Die, and he talks about branding yourself in the industry. And I was like, oh yeah, I was talking to my podcast. Oh, I just booked this guest from Healthcare Highways, and we were literally chit chatting about you as you came up too. It's like, there couldn't be more coincidence in the moment. So anyways, regardless of that, really appreciate you agreeing to come on. I think we're going to have a good conversation today. Yep. The idea behind the podcast, which I shared with you, of course, is the self-funded industry, everything that touches and feels and indirectly or directly related to self-funding. So today we're going to go into networks, and I really want to pick your brain on the role of the network, the good and the bad, what problems you guys are trying to solve. But before we do that, if you don't mind, I'd like to take a couple minutes for the folks to get to know you, both personally and professionally, talk about your career, and of course, what led you today to be the EVP of Healthcare Highways, EVP of Sales, correct?
Yeah,
cool.
Absolutely. So my background, I'm a native Texan, one of the few that seems like remaining. We have a lot of people that have moved to Texas, and that's awesome, and we welcome them. But born and raised here in Austin, grew up here in the Dallas Metroplex, went to the University of Texas and moved back. And really early on, 1 year out of college, I got into the healthcare industry. And the interesting story is I started with my uncle, who is our CEO at Healthcare Highways, with a company called Corporate Health Plans of America as a consultant. And I worked there for a few years, and then I went out to start working with TPAs, MGUs, and building products for those TPAs. And as you may or may not know, I went out and started my own brokerage firm shortly thereafter. And really what was interesting about growing up in the space was, and I may be getting forward on the next conversation, but was really trying to make a difference into the marketplace. Mm-hmm. And before I go into that conversation, I'll just tell you from my family history, I've got an 18-year-old son that's going to be a freshman at the University of Texas at Dallas, and a 21-year-old daughter that's going to be a senior at SMU. Love to work out. I'm surprised I haven't seen you at Cowboys Fit.
Yeah, maybe we just have different schedules. But
I'm a
sure
5-day-a-weeker.
Yeah, we'll probably see each other up there next week.
Or in the morning.
Yeah,
so
in the morning. Yeah.
They're often. But yeah, personally, grew up playing baseball, was a wrestler, did a lot of basketball as well. Did not play football, did not even grow into my frame until after college. I was a very skinny kid growing up. So very strong sports background, very much into fitness and travel. So that's a little bit about me on the personal side.
Well, that's interesting. I think I had a similar growth trajectory to you, although realistically I was kind of like, I was a big kid early on, and then I stayed 5'8" from about 13 on. But all I've really done is get, thicker over time. But, try being 5'8". I can't put a lot of meat on this frame before I look a little short and squatty. Right. But, same as you, obviously I use my sports background to, really underpins a lot of what my wife and I do. We're try to stay healthy. We work out very consistently, try to work out together when we can. But I think it's pretty common, I would say, in our industry, maybe even just sales in general, the folks that there's something about the discipline of growing up, understanding goal setting, the drive, the internal drive that you have that makes you good in sport is also going to make you good in sales. So I'm sure you use some of that skill set to transition into the career world as well, right?
Yeah, what's interesting is when I went to the University of Texas as a sophomore, I thought I was going to play baseball, and quickly my dad gave me a job and said, if you can figure out how to go to school, work the job, and play baseball, you can try it.
Yeah.
But what he did is he taught me, I went to work for him. He was a VP of a credit bureau. And what that simply means, it's a fancy way of saying a collection agency.
Okay.
And I was on straight commissions through college and put myself through college by collecting bills from people that didn't want to pay their bills. Mm-hmm. And they were medical bills, many of them, for the local public hospital. So I learned rejection quick. I learned call metrics. I learned how to get people to come in and make a commitment that day. And so I was indirectly being trained for sales and the rejections that come with sales. And I transitioned out of that into a sales industry because I understood the ability to earn a living was pay for performance, right?
Yeah, absolutely.
The more work I did, the more successful I was, the more I made. And that's really what started my sales trajectory, is working for my dad when I was in college at the University of Texas.
Well, that's very cool. And the collections industry, right? I feel like that's a tough industry,
very
right?
Tough.
I mean, especially because the people that you're talking to on the other end obviously are in, dire financial conditions most of the time. And so you're trying to, of course, encourage them to pay bills that they may or may not have the means in which to do.
Right.
So I couldn't imagine probably a more difficult sale, although you're not technically selling a product, you're selling them on the idea of you need to pay off this debt, right?
Right.
But I think of that, like the other industry, or I think the other sales training ground that I think that really prepares people is the ADP, like the payroll style. I mean, talk about a difficult thing. And I remember having some buddies that that's how they started directly out of school. And he was telling me about going and literally how to get into, buildings and knock on doors and how to get past the gatekeeper. And it was all this science behind the rejection aspect and getting over the rejection aspect that early on, I didn't start sales until I was later in my career. I looked at that and said, man, I don't want to do that. I
Right.
can't do that. I mean, it seems off-putting, but it also does prepare you to have very thick skin. And if you can do that, you can sell anything, right?
Yeah, and I think what helped me was we were required to carry an alias. So it wasn't me calling, it was this persona.
For your safety, right?
Yeah, for your safety, but also you're building this persona that it's not a personal rejection, it's a business rejection. But back to your point, it wasn't even necessarily the means of whether they could pay the bill. It was the commitment of when you're collecting, you're just trying to get them to understand that this is a commitment you made and you need to make some gesture towards it.
I see.
We would collect $10 a month, but they were making some commitment to pay off that debt. So it was really getting them to commit to something and understand that that was a liability and a responsibility. So yes, you absolutely made accommodations for those people, but it just taught me how to listen, because you had to inquire what's going on in their life. How did they get here? What's their reasoning for not wanting or not being able to pay this debt? So it did help me on the needs analysis, if you will, to develop listening skills, but also the persona, to your point of rejection, is a lot of salespeople really are relationship based, and they have a hard time with rejection, and they take it personally.
Yeah.
And I think that was the two things I took away from that life experience.
Well, that's awesome. It obviously prepared you well, and your career trajectory is indicative of that preparation. I do want to ask you specifically, though. I know you mentioned a little bit ago you did start a benefits practice, correct? And I noticed, at least if the LinkedIn timeline is correct, within about a year and a half, you had sold that practice to, I don't know if Gallagher, right? So tell me, how did you build something so quickly and able to end up selling it off to them? And you worked for Gallagher for a number of years after that, correct?
That's correct. And that's a little misleading, because it's the timeline's accurate. But when I left the TPA and the brokerage firm that I had created with them, the way we split is I took my business with me. So I had worked for those clients for 6 years. And then I established my own agency. And then literally the second month that I started my own agency, I started getting phone calls.
Wow.
From multiple brokerage firms recruiting me. And they were all big houses. And I just wondered, what do they have that I don't have? Like, I'm an independent. I had a $1.2 million book. It wasn't huge, but it was providing very favorably for me and 2 employees. And I was interested, so I just started the dialogue with them and started to have conversations. And I really built a relationship with the gentleman by the name of Dwayne Leftwich, which was the market president of Gallagher at the time. Okay. And really, it was all about the relationship I formed with Dwayne that really interested me in going to work for Gallagher, and really wanting to learn what do the big houses have that a small independent agency doesn't have. And so that transaction occurred 18 months. It took him about 12 months to get me really to listen and hone in on it. Had no interest in working for a large firm. And so for Dwayne to do that just shows you how relational he was and how impactful he was in my life at that time.
Well, what do you think was, did you have your finger on what exactly, like you said, is like you were surprised to be getting phone calls so quickly. Did you ever, figure out exactly what it was that was so attractive about the business that you had built so quickly?
Yeah, I think a lot of the consultants that I went up against were competing for my business, and we had a very strong retention rate. I always tell everybody my customers and my consulting firm became my friends, and so I knew them all personally. I knew them all at multiple levels, and we didn't lose business. We really didn't, and we had a strong base, and so that was attractive to those agencies, but they also felt like what we were doing, they could grow exponentially if we were part of their team.
That's cool. And so, I wonder why, if you built that such a deep level relationship with your clients, then obviously the transition and going into a bigger shop and having a different name, on the building, does that impact that at a certain level, or is that something that's easy to kind of explain the reasoning behind it so that you're still retaining those clients?
Yes, you're selling your customers that you're going to have more resources and more tools at your disposal, and that you're going to be part of a bigger team. But if I could be quite honest, transitioning to a larger firm really wasn't good for me. I didn't like the methodology. When you go into a big firm, there's a certain way they want to do things. It doesn't always align with your beliefs and your thoughts. And really, you're working into what they call their way of doing things. And so everybody gets in that shuffle, even the customer, your staff, yourself. And so I really became disenfranchised with that sell. And really started to think about, was that a good decision for me? Was that a good decision for my customers? I think the customers at the end of the day were well taken care of because the service team that I had stayed on those accounts, and they were the best service team that I could find in the business. And so they were well taken care of, but I really started to question, is this where I'm supposed to be?
Mm-hmm. Mm-hmm. So what approximately, what was that, about 10 years ago? Or
Yeah, so I sold in 08,
okay.
And I stayed through my 5-year commitment in 2013.
Okay. And so then obviously now we can get into that. You've left the broker world and in comes Healthcare Highways. So walk me through the story of that transition.
Yeah, and I kind of jumped ahead earlier into I'm always known to jump into the meat, so I apologize.
That's perfect. No, it's fine.
But I started to tell you I worked for my uncle back in '95, left that agency to go start my own and work with these TPAs and build products, and then I got to Gallagher. And then I was going to leave in 2013, and I was going to go do something else. I was kind of disenfranchised where the industry was. Obamacare had just been passed, ACA, and everybody was confused what was going to happen. Mm-hmm. And I'd become the ACA expert at the Gallagher benefits shop here in Dallas, but that's not what I wanted to be. I didn't want to be the the product knowledge expert inside of an agency on compliance and logistics and all those things. And so what I started to do is do a self-assessment. Similar to our encounter with at Tri-Tip, my uncle and I ran into each other because we hadn't worked together in many, many years. And he started to say, hey, what's going on? And he could sense that I wasn't really happy where I was. And I said, I'm going to do something differently. I'm either going to buy a restaurant, I'm going to buy a company, I'm going to do something, but I think I'm done with healthcare.
Okay. So you wanted out. You were done completely from the healthcare industry. I mean, was it a slow burn to get there, or was there any moment in time where you're just like, that's it? I mean, was there something more monumental that happened that wanted to drive you away?
I would say it was a slow burn. The first probably 2 years, they kind of left me alone. Everything was great, and they started to transition in those belief systems. And I just started to look at the industry and started to see some things that I'm like, wow. There's some misalignment inside brokerage firms with carriers, and that's all I'll say there. And so I started to think about it and what I wanted to do. Did I want to start over and so forth? So the last 3 years of being at that big house, I was really struggling to really find the passion to go back out and grow the business and believe in the business. But as I started to evaluate what was out there was a lot of uncertainty with healthcare as well. Single payer discussions, value-based care discussions, what's the impact of Obamacare and so forth and so forth. So what my uncle was bringing to me was something different of, hey, we're going to actually take some of the language in the new bill and we're going to create an opportunity out of it.
Okay. So was it just an idea at the time that you guys had this meeting, or had they put things in motion to build Healthcare Highways out?
Well, if you know my uncle, he's a bit of a poker player, so he was keeping it close to the vest, and it was an idea presented, but he had already established the company in 2010.
Okay.
He had already been testing it with some hospital systems, and he was really recruiting me to formally go full live in the program. And what he was trying to do was put together a team of highly experienced people. I'm 50 years old now. I've been in the business since 94, so 27 years in the business. That's the average of the team that he's been recruiting.
Okay. So obviously you're bringing some real heavy hitters to the table, some people with extensive industry experience, relationships, I'm sure as well. So what was your initial role at Healthcare Highways when you started?
Yeah, so my role was actually to come in and build the small group level funded product, grow it, and sell it in Oklahoma.
Okay.
And then establish a team, grow the team, and bring it into Texas and Louisiana.
Oh, so you started in Oklahoma first?
Absolutely.
But where was the home office at the time?
It's always been here.
Okay.
But we started in Oklahoma. I don't know, a lot of people don't know that our CEO, my uncle, is a former Olympic gymnast.
No. Oh, wow.
And he was a national champion at the University of Oklahoma. And so he's got strong ties in that state. And the opportunity to come there and build a network was much more readily available based on relationships. So we thought we could build that network and get started in that state quicker. It was always going to be a regional play, Texas, Oklahoma, and Louisiana. Mm-hmm. And so we built that state first, and then we moved into Texas, which is a much bigger state, which is a much bigger build.
Well, I was going to say, yeah, I actually was a rep for Sun Life for a number of years selling Stoploss.
Yeah.
in my territory, the biggest part of my territory actually was Oklahoma. So, some people, you'll see you're on the totem pole of reps and you're earlier on, you're going to get territories that wouldn't be considered as rich or fruitful, of course. But I actually discovered pretty quickly, I loved going to, I would go to Oklahoma City and Tulsa in the same little circle and ended up building some very strong relationships there. And I actually ended up preferring, I had covered West Texas as well and had some great folks out there. Couple of folks in Dallas in terms of brokers that I worked with, but really Oklahoma was my bread and butter. And so I actually decided to really, intensely focus on that marketplace and discovered quite a bit of self-funding there, quite a bit of opportunity there if you know where to mine it. And I have a very fond, a soft spot in my heart for that marketplace. And then I discovered, you got some folks like, Dr. Keith Smith and his bundled surgery, and you've got, Jay Kempton and his Kempton Premier Provide. You've got some really cool ideas coming out of that marketplace as well that most people don't know that if you're not outside or if you're outside the state itself.
Yeah, and I would say that Oklahoma has been very innovative related to healthcare and free market. Dr. Keith Smith, you talked about, we work with Jay Kempton, great organization, but we've really evolved into working with those guys over time because, again, they're doing things so different. You have to understand them and their purpose and their mission and understand if that meets with what you're trying to accomplish. And as we talk about the conversation of what we do, it'll make more sense of why we have to explore those entities before we just start working with them.
Sure, and that's a great segue. Obviously we want to spend the bulk of the remainder of the time digging into this idea of a network. And, people have perceptions of what a network is. They have strong opinions, I think, either way of what, the real value or whether a network is even a real thing at all. So before we get into specifically, I think, what you guys do and the difference that you're offering, could you help me define a network? Let's talk about what people think of when we think of an insurance network.
Absolutely. So a network in its simplest state is a series of contracts that you establish that say you're going to reimburse either in some form, way, shape, or form on a percent of charges, a case rate, a defined number off of a billed charge amount back to those providers. And in exchange for that, you're going to have benefits that steer members or patients to those providers inside of your framework of your network.
And so now that we know what it is, I alluded to the fact that there's strong opinions either way. Tell me kind of what the problem is, or over time, what has become why is that arrangement have a spotlight on it is perhaps not the most aligned in the way that they're paying, or not the most, I would say, beneficial to the actual member. Could you dig into that a little bit?
Yeah, I think it's the whole relationship of understanding its stats. People report on discounts, and members and patients don't know what discounts mean. They don't know what the starting cost is. They don't know that hospitals all charge different amounts. At the end of the day, when they go to the doctor or hospital, they're not told what the discount is. They're told, here's what your responsibility is. And so there's no way for them to manage cost. There's no way for them to manage, is this a good deal or a bad deal? And when consultants are out there, they have no way to measure anything other than what the industry has kind of developed is, what's the discounts? Mm-hmm. And they always assume that Blue Cross has the best discounts or United has the best discounts. And again, it doesn't get down to cost. It gets down to discounts, which is a metric off of a billed charge amount that has no real value back to the member or the patient.
Yeah, I've heard the analogy before. You go to a store and you go, oh, that shirt's 50% off. That's a good deal. Well, 50% off what? Did they jack up the price first and then say, hey, it's 50% off? When you're looking over here, being misdirected rather than knowing, like you said, what is the actual cost of the service?
Correct.
Or what truly is your cost as a provider for this service, and what's your margin? And then what is my obligation as a consumer of that service to pay? It's so convoluted, it's so murky, and of course, we could spend an hour probably on the opaque nature of the payment system. But now enter healthcare highways. So your uncle has this idea, right? He starts beta testing it, puts it in motion. What is it? What is he offering the marketplace that's different than the traditional network?
Yeah, so what started with Obamacare and the ACA language is there was language that President Obama really wanted people to move towards value. They wanted the Medicaid and Medicare contracts to move towards value-based care. And they put some deadlines in there that they wanted to have hospitals and systems move towards value-based care, by certain deadlines. And so what we were going to do is set out and start to build value-based networks. What we found out is hospital systems and markets have a different readiness and willingness to move to value. Some systems, believe it or not, like the fee-for-service market because it's working for them, for the system. But there's a lot of hospitals that are really eager and wanting to move towards value. The second thing we're solving for is this is the only industry I can think of that has an inverse relationship to cost and quality, right? So just because you charge more does not mean you get better service. The example to your clothing alliance analogy would be, I'm going to go to Neiman Marcus and I'm going to go to Walmart and I'm going to pay the same for those services. I would presume that Neiman Marcus has better quality. Well, in healthcare, that's not always the case. Sometimes the lower cost system has the higher quality based on outcomes and independent reporting measures. So we wanted to marry those two. And I think this new transparency bill is going to be really interesting to see how it starts to flush out some of these free market programs that are already out there that are measuring cost and quality. So what we were trying to solve for is a platform to actually work with hospital systems and partner with them for the benefit of the member, the patient, the employer. And that's really our vision.
Well, so when value can be sometimes subjective. So what kind of metrics are we using to establish value?
Yeah, so there's 10 quality metrics and 5 utilization metrics, but a lot of it's based off values already out there in the Medicare Advantage space. And that's really the footprint that we use around those measurements that are already there. Physicians are already doing it very, very well. And they're already doing it very, very profitably because they're demonstrating high value back to these Medicare Advantage plans. The challenge is to take that to a commercial market, and how do you do that?
Okay, yeah, and so I'm thinking when I think of the value-based care, I hear value often referenced in like a reference-based pricing arrangement. Like, hey, this is a value-based payment methodology rather than, hey, just off a discount off billed charges. So is there some alignment there? You guys are doing some reference-based pricing, correct?
Well, not on a contract basis. We do reference-based pricing to wrap around our network where we don't have coverage or don't have contracts.
Okay.
But to answer your question, providers just don't want to give you deeper discounts and call that value. That's true. But what they are willing to do is they have to give you a unit cost advantage, and then they have to have some incentives to earn additional revenue based on performing well. So if they lower the cost of the plan and improve the well-being of the patient member, they should be rewarded for that. That's value.
Yeah, and I would agree 100%. There's this notion that if you are going to reduce costs, for some reason that has to also mean there's going to be a decrement to the actual value to the member, or the plan is going to have to suffer. They're going to have to pay more out of pocket. You're going to have to shift costs to the member, whatever, however many levers you want to pull that it ends up being detrimental to the member. I would disagree, and that's why I'm strong advocate for self-funding, because if done right, you can have a win-win situation. You can lower the cost, and the member is going to have, a richer plan design or zero out of pocket, all sorts of steerage. Maybe we're adding additional benefits onto the plan that they didn't have before. There's so many things that you can do that actually are aligned in the incentives that has been broken, in my opinion, for a long time in the marketplace, which, hence why you guys are doing so well. So let's talk about more logistical. I presume it has to be a self-funded group, correct, to work with you, or no?
Today it does. So we actually have a health plan that's a national carrier that's filing a fully insured product in the state of Texas with our network.
Okay.
So that'll be new for 1/1/2022.
Is that not announced yet, though? I guess they're
not announced yet,
okay.
But it will be coming. We also have level funded products with them as well. We also have exchange products where we're on the individual exchange in Oklahoma. So we do serve the individual exchange marketplace and with 2 different carriers in Oklahoma, and we'll be bringing that to Texas as well. But put those aside, all that we do on marketing is on a self-funded basis to large employers. So what's a large employer? We can do level funded down to 2, but really we focus on 200 plus on the self-funded side.
And is there certain administrators that have access to the Healthcare Highways network?
So there is. It's again, healthcare's local, and the way we work with TPAs and payers is also local. So when I say that, in Oklahoma, I've got over a dozen different TPAs I work with. In Louisiana, I've got another dozen that I work with. Louisiana and Oklahoma are just now moving to value-based contracts. Texas, we started with value-based contracts. So we do have a much more scrutinized process of looking at TPAs. In Texas today, we have approved web TPA, and we've approved Kimpton to work with us in the state of Texas. But we're also working potentially with 90 Degree Benefits and their TPAs.
Okay.
So we're going through a vetting process for each of those, and that vetting process is really capabilities-wise is, do they have the internal structures to file claims, to route those claims effectively, to pay our providers timely, to make sure there's no member abrasion, and did they have a business plan? Like you said earlier, what is their business strategy? If it's just a group or two with us, that's not really going to fit our business model. One of the things I really, really appreciate now that I did not appreciate as a consultant is all the time and energy it takes to set up vendors, to implement a vendor. And so to implement a TPA, it's a 90, 120-day process to get everything coordinated and set up, and that costs money and that costs time. So we want to make sure it's for the right opportunity, and we're welcome to talk to other TPAs, and we are in discussions with multiple. But if there's other TPAs out there, we're welcome to talk to those from our partners.
Yeah. So I mean, you mentioned a vetting process. It's just to ensure that they're I guess obviously there'd be a philosophical alignment, but also from a strategy standpoint as well. Because your solution, I presume, is not for everybody. And,
Correct.
that's especially working with Web TPA. I actually worked prior to PlanSight. I was at Amwins. And, yeah, Amwins owned Web at the time. And I think I met with Mitch because of that reason, right? Trying to figure out how we could figure out how to work together. Of course, Stoploss being a crucial component of implementing everything else is you got to make sure that the stop-loss carrier understands the strategy, understands the pricing, the potential for savings and things like that, so they're competitive, and then everything else falls into place. So profile-wise, you did mention from an employer perspective, traditionally 200 and above, probably even with Web, we're talking thousands and above, right?
Above, yep.
So realistically, that's your sweet spot, right? But when you say there is a level funded product, could you tell me a little bit more about how that's servicing that smaller end of the spectrum?
Yeah, so like National General's that level funded program.
Okay.
And so they have their own suite of services. They outsource to a TPA out of Chicago that pays the claims. They use our network. They can also offer national carrier networks like Cigna and Aetna. But we have a price advantage because they know our unit cost is significantly less than those national carriers. So they market that and sell that, and they just lease our network in that arrangement. But I do want to say one thing related to the Web TPA arrangement. Not a lot of people understand this about us because we are a network company. But we have a program in place where we actually source the Web TPA claim system, but we actually function as a full health plan in Frisco. We have the operations team here.
Okay.
We do everything soup to nuts except use the claim system to adjudicate the claim. So we source that and lease that. So what we do for Web is we administer all the plans underneath 3,000 and above that they want to go after, and we become their kind of back room for those health plans. And we're starting to do that for several captive insurance companies that want to use our services and want to go out and sell our program.
Well, so, I appreciate you bringing that up. I'd like to understand, though, you're talking about markets for a moment, obviously starting in Oklahoma and then Louisiana and Texas. Tell me why geographically, are you staying within the confines of these states for the time being, or is there an idea to expand beyond those states as well? Yeah,
so originally it was just going to be these 3 states, but it's interesting. You're very intuitive to ask the question. Just recently, at the last board meeting we had last month, we've approved a national expansion.
Okay.
And so we're going to be going into 25 markets. We're not going to build states like we did in this region. We're going to build markets. And so what we're working with Aon nationally as a growth partner to identify what are the 25 markets that are most ready for value-based markets and have the highest need for value-based contracts, and what are the proper systems to go out there and target. And so we're going to go into 5 states first for next year, and then we're going to, markets, 5 markets next year, and then we're going to expand each year thereafter. So we have a strategy over the next 3 to 4 years to go out and grow this market strategy, but it'll be built around the hospital systems that have the right demographics in alignment to go out and build value-based contracts.
Well, is there, I guess you said the right system, so are there situations where, presumably this is not a fit, right? Or whether or not you guys disagree with the strategy, or maybe they're not open to the way that you guys are, focused on value versus the paying the traditional way. What's a situation where it just doesn't work?
Yeah. So there's examples of that in Texas, and I don't want to call them out, but there's examples in Texas where one of the national carriers may have partnered with a certain system, but if they're the higher cost system and there's no discount or decrement off of a broad network, that has very little value to the customer. So I'm going I'm going to disrupt my network and shrink access, but I'm not going to save you any money. So that would be a scenario when if you can't get the proper alignment, so typically what you're looking for is the non-preferred or the system has the least amount of volume compared to the dominant system.
Okay.
And is higher quality and willing to invest in that quality to get you to the right price point. The feedback we get from the national consulting firms is we're willing to look at a high-performance network like Healthcare Highways, but you've got to drive savings of at least 20% for us to do so. Okay. And so that's our target, and we've achieved that in all of the major metro markets in Texas is we're 20% plus on savings when we talk about plan cost. So you got to look at the right dynamics to say, can we go in and build a product that's going to support the model and get the consultants and the employers willing to buy that product.
Well, and that's what I somewhat myopic in my view, just because I spent so much time as a stop-loss rep, and banging my head against the table sometimes trying to convince underwriters of the savings potential. Like you described, you had to prove that there's 20+% savings. It takes a while, but when there's enough data to support it, the stop-loss carrier, I've discovered over time as I've, being in this position here with the podcast as well as PlanSight, we often get connected with what's the next technology or what's the next solution that's out there. And so there's a vetting process, right? And I've discovered that over time, especially in the self-funded world, that the stop-loss carrier ends up being the proof in the pudding. When you convince them that there's discounts I hate the discount, but there's a reduction in cost for whatever arrangement you set up. And they're willing to give you better pricing because of that and better aggregate factors and overall, maximum liability numbers. Then you're going, okay, well, we've hit the mark because we've convinced the person that's assuming the risk that we're doing something right? And so I presume you guys have gone through around the fishbowl a couple of times with these carriers trying to prove out the data, correct?
We absolutely have. And again, great question. Thank you for asking it. We've worked with an actuarial firm that we took a multi-month process to go through and actually say, okay, here's our contracts. Here's what they're going to yield by market. We take the average of that market yield from those national networks that are out there, and we compare them, and we see what we're going to yield. And then we share that data because here's the challenge being new into a market. What do stop-loss carriers want to rate you? They want claims data. Mm-hmm. Well, when you're new, you have no claims data to run through them, and they don't know how to interpret contracts. And so what you have to do is do that for them and have a third-party entity do that. And we've done that. And so we share this analysis. We've gotten feedback. It's one of the better analysis that the market's seen. And so we get credit for that. But here's the challenge with stop-loss carriers. The number one thing they care about is large claims. Mm. What are your outlier provisions? What are your outlier contracts? And that's really where we excel is we have really, really strong outlier contracts as well in large claims. So when you take that into account, we're getting good credit from the stop-loss carriers, but back to your earlier point, we haven't finished the process because until we get enough claim volume to demonstrate what we're getting from a savings from care coordination, care navigation, on top of those outlier provisions, on top of those aggregate claim contracts, we're not fully there, but we have seen like in Houston, 31% decrement off a major national carrier. So we've got very, very strong stop-loss contracts. Now, that varies by stop-loss company, and what I've learned, and this has been really the growth of my experience, is not all stop-loss carriers have the ability to rate networks the same. Mm-hmm. And so we have a lot of value that we can provide feedback on who understands networks, who's got it rated aggressively, and who doesn't.
Now I'm wondering, just out of curiosity, we don't have to name names, but is your approach more aligned with the bigger carriers, or is it the smaller, nimble, maybe MGUs that see the value, or is it both? I mean, I'd love to hear the feedback you're getting there.
Yeah, so that's a great question. We have a lot more experience and success with the MGUs that really work it at the local level, mm-hmm. and have the ability to sit down and talk to you about your contracts and understand it. But we do work with the nationals as well. But what we find is we work with a lot of the consultants' preferences, and a lot of the consultants work with forget the name of where Clifton Browning is.
Oh, Stealth. Yep.
Stealth. So Stealth does a lot of the analysis for us, mm-hmm. For those large broker houses. So we do work through them as well, and they work with top tier firms. But from a pure network yield, we're going to get a higher yield from a lot of the independent local MGUs. Mm-hmm.
When I asked it, I kind of perhaps knew the answer beforehand, but I wanted to make sure. Being from an ex-rep from a very large house. I experienced the good and bad of the scale that they have. And, the bad, of course, is not enough time and attention could be paid to certain solutions because there's not enough history there, or there's just not enough data, or that, again, they're thinking in terms of volume. Maybe there's just not enough premium for me to take a flyer on something like this. So, I'd always love to hear, is the proof really in the pudding? And that, from my perspective, that's when, there's more objective proof, right? So we're talking future, right? We talked about your future expansion, but, maybe more broadly, what does the future of a network look like in your opinion?
So I think it's evolving. This transparency bill is really creating an opportunity. Reference-based pricing's out there. Hospitals are going to have to figure out how to take this next step in the evolution of healthcare, right? How are we going to deal with this transparency where potentially rates and fees are going to be exposed? And how do we work with these carriers that are going to look at these rates and fees and start to leverage them? Mm-hmm. And so I think the future is healthcare highways is in a unique position, right? When you have a high-performance network, and let's call it, a subset of a broad network, if you will, then you have the ability to say, look, we should have the lowest rate in the market because we are not working with your competitor across the street. And if that becomes the benchmark price point, then actually strengthens the hospital's negotiating position when we go to transparency. The second thing I could tell you is the evolution of how both a network and reference-based pricing can coexist, right? It's not to say that free market programs are bad for the market. They're not. But how do they coexist with a network strategy that has certain things to maintain the network integrity? Mm-hmm. And so what I think you're going to see, and you're already starting to see it from some of the people we talked about earlier, is an evolution to figure out how to manage cost at a local level, how to protect the providers that are willing to give you, market-leading pricing, mm-hmm. and how to make sure that if they're giving high quality, that they're getting the care come to them. And we think at Healthcare Highways, the best avenue to do that is through primary care.
Okay.
Primary care is the lowest cost entry point, and it's the best opportunity to establish a patient-provider relationship and to help navigate a complex healthcare system. So everything we do is around promoting primary care and making sure that independent primary care stays independent. Right now you have carriers coming into the market trying to, purchase provider groups, and that's bad for the system. That increased cost, and it's not good for the end user at the end of the day because
they're part of a system, and right, they're just the first step and the feeder into the system, right? Say, hey, you need to go over here and get this procedure, right? They're not necessarily if there is that affiliation, correct, there's not necessarily an objective recommendation, perhaps, or at least there's the appearance, perhaps, that there might be other motivations, correct, and feeding them into the system to go up the ladder, more expensive procedures and things like that. Right?
I'll go one step further. Okay. It's evidence-based that it costs the system significantly more. Okay. It's just proven. So they're not aligned with the same incentives that an independent physician would have that is built on value. So again, where is the market going? You're starting to see segments of a network or a health plan carved out, right? Mm-hmm. Direct primary care, direct orthopedic care, renal care, mm-hmm. Chiropractic care, Arasti. There's all these pieces that are being carved out, and those aren't bad. Telemedicine and telehealth, how that's expanded through COVID. I think the challenge that I see, Spencer, is really the coordination of care gets lost when you start to fragment parts of healthcare. Yeah. And that's what Healthcare Highways is trying to explain is the network value is really in the coordination of care, either through care navigation or care coordination or both. And the ability to communicate amongst these providers and get it back to the lowest cost entry point of primary care is really, really important. I can't drive down the street without hearing an ad for, hey, come directly to your orthopedic. You don't have to go through your primary care. Well, that's great, but that's expensive mm-hmm. and not necessarily necessary. Mm-hmm. So we have to think about that from a healthcare standpoint. How are we going to think about the coordination of care from these carve-outs that are not necessarily inherently bad, but we don't want to lose the coordination, which is really, really important.
Well, I like you position it as the fragmentation of care. I just released an episode today of a gal, Megan Chiarello. She's a marketing expert for WellNet.
Yeah.
And I like the notion of, and we talked about this, the fragmentation is great, and I know consultants that do a great job of helping you pick the best-in-class vendors and connecting them all together and coordinating that and implementing that. But that fragmentation, like you said, has an inherent level of difficulty added to the equation, and there are things that can fall through the gap. And so, the idea of something like a WellNet, I haven't fully investigated their solution. I've never worked with anybody that implemented it, but the story around it, of course, is the simplification. She mentioned the product. I'm going to productize the solution. So it's a finance mechanism, but we've turned it into something that you can touch and feel. And, it's got coordination that's, involved in that. So I'm interested then, you talked about that fragmentation, kind of the future of where we're going. Do you see, I want to ask you about the data. You talked about situations where you might be 31% or whatever the number is below that traditional. Do you think there's going to be a critical mass where that happens over and over again, where it's really going to undermine the notion of a traditional network altogether? I mean, do you think that's the endpoint we get to?
Yeah, if I had to tell you what my vision was personally, I think you're going to see systems competing against systems, and I think that's good for the members, right?
Sure.
If let's just take locally, if Baylor has to compete on quality versus THR or Medical City is our local partner with HCA, that's good for the member. They have to compete on quality, and then they have to manage their margins, which is important. The thing we have to understand is we want our providers in our systems to make a profit. That's good.
Of course it is.
We want them to make a healthy profit, but a fair profit. But we also want them to lower the total cost of care and improve the well-being of our patients. And so I think if the systems start to think about if they can report and provide the outcome-based data, which they are starting to do, and they can show that there's good value from going to their system, then that's good for the market. Another thing that's good is HCA and locally, Medical City, does not employ physicians for the most part. They work with independent primary care. So they're the best avenue to help keep independent primary care independent. And that's really, really important for us, and we think for the market. So I think what you're going to see is hospital systems are going to develop their go-to-market strategy for value, and they're going to start to compete on value. And I think that's good for the marketplace. So you asked me, does the broad network go away? I don't think so, but I think it may become more of there are multiple options inside of a single employer. You have your high-performance value plan with one system. Mm-hmm. You may even have it with the other system, and then you have your broad coverage for other people that want to pay more for it. But I think you have to start to think about plans that charge appropriate contribution based on outcome-based health plans. Mm-hmm. So if they're generating 20% savings, you need to charge 20% less for that program. And then you've got hospitals competing on value and cost, not just on discounts.
Well, yeah, and so you're kind of describing, I guess, a narrowing of a network over time. I mean, is that what you're saying with those value-based? There is a reduction in the scope of the network, but there's a value
I'm almost
emphasis.
Saying you're choosing your care delivery system.
Okay.
Do I want to work with independent primary care and go to these hospitals that have high value scores and are lower cost? Or do I want to go to a health system where they own and employ all the physicians, and once you go, you get your MRI there, you have your surgery there, you see your specialist there, and you go through that market, and you're going to pay 20% more for that. So I think what I'm saying is I think a market shift to thinking about how am I going to get my care delivery today? Mm-hmm. Right now, how do you find your doctor? You either know them or somebody referred you to them. But there's not a whole lot of evidence that people do before they walk in. It's word of mouth referral. Yeah,
and that's obviously you have no visibility into that potential of a positive outcome. Sally told me to go down here, so I'm going to go down here, right? So I know we got, in the interest of time, and I know it's Friday afternoon, we got get you out of here as well. Kind of final thoughts. I think we've all delivered those to a degree. But like if I'm an employer interested in the services you guys provide, or if I'm a consultant that wants to know more, what's the best way to get in touch with you all?
The best way to get in touch with me is send me an email, chris.wilson@healthcarehighways.com. You can go to our website as well, healthcarehighways.com, sales@healthcarehighways.com. But we're very responsive. We're locally based. We will respond and get in touch with you, and we'd love to have the conversation. But we do want to make an impact and do our part in healthcare. We're very open to talking to other vendors that have new ideas. We don't think we've fixed healthcare, but we're trying to do our part in innovating healthcare.
That's awesome. I love that, man, and I definitely want to leave that there because I think that's outstanding. And I presume also the offer will be on the table for one of those prospects potentially interested to maybe tour the office at the Star as well.
We did it this week, and we love having people up to our office at the Star.
Awesome, man. Well, I hope to see you at Tri-Tip or the Cowboy Fit soon, man. So really appreciate you coming on. Thank you for your time. This was a very enlightening conversation, and I hope to do it again soon.
Thanks for having me. I appreciate it.
My pleasure, man.